Welcome to Back from the Abyss. I'm Dr. Craig Heacock. Today I'm doing a solo episode. This is the Art of Deprescribing. One of the main consequences of having a psychiatric healthcare system largely based on the brief med management visit is that patients tend to end up on more and more medications the longer they stay in the system and the more clinicians they see. Again, when all you have is a hammer, everything looks like a nail, and the medication management mindset is that both psychiatric and psychological symptoms can and should be primarily treated with medication adjustments and additions. Add to this the fact that so much of what we call treatment-resistant anxiety or treatment-resistant depression is actually either a primary or secondary consequence of trauma. And as you have all heard me discuss in a number of episodes, most psych meds do little to nothing for trauma. Thus, the most complicated, the most symptomatic of our patients often end up on a long list of psych meds, many of which are almost surely doing nothing, positive at least, and may well be causing significant side effects and/or withdrawal symptoms if their dosing schedule is altered. And so, this is the situation in tens of thousands of psychiatrists and psych NP offices across the country. A patient shows up with some chronic, difficult-to-treat depression or anxiety of some unknown etiology. They bring this huge list of meds that they've tried or either don't work, have caused side effects, and or they already are on a long list of meds that they don't think are helping. So today I'm presenting here 6 guidelines and ways to think about the challenging, but ultimately super rewarding task of trying to simplify, pare down, and sometimes even totally eliminate these handfuls of pills that so many people are taking daily. Step number 1, make a biopsychosocial formulation for each patient. While it's tempting to jump right in and start peeling away potentially offending meds, the first step of successful deprescribing must always be putting together a psychiatric formulation. Now, what do I mean by formulation? Let me give you an example, giving you both the med management perspective and then the biopsychosocial perspective of the same patient. Here might be a med management DSM type description. Say, 28-year-old married white woman with major depressive disorder, recurrent severe. Here would be a biopsychosocial formulation of the same patient. Might go something like 28-year-old married white woman with early adolescent onset, recurrent severe hypersomnic depression, clearly with major hormonal influences as evidenced by premenstrual worsening, in the context of early childhood emotional neglect due to mom's alcoholism, and an apparently neurotic and perfectionistic temperament, now pulling away from her family's fundamentalist church with emerging estrangements. Hear the difference? The formulation is the patient's summary story, and it can help us understand them as a unique individual, as someone who needs and deserves a thoughtful treatment and deprescribing plan. We have to know who the patient is, the why of their story, what actual bona fide diagnoses they might have, versus how much of their psychiatric and psychological symptoms are or were due to temperament or trauma or current stressors or existential despair or so many other factors. The biopsychosocial formulation begins to give us the roadmap we need to think about which psych meds might actually make some sense for the patient versus which were added so a medication manager could feel like he or she was doing something. In this example, major depressive disorder, recurrent severe, is a wastebasket diagnosis. It's a lazy diagnosis. It really says nothing about how and why the patient ended up in our office. And critically for this talk, it gives us no guidance whatsoever about what to do with the meds or how to think about deprescribing. In contrast, the biopsychosocial formulation provides a number of important clues. This patient's early age of onset, the hypersomnia, the recurrent episodes, and the hormonal sensitivity all argue for a subtype of depression which does very well with the proper meds, such as lamotrigine and ketamine. Moreover, her trauma history and more recent estrangements strongly argue for being in psychotherapy and/or somatic therapy. And if the psychiatric formulation were altogether ignored, this patient would then be at significant risk of unconsciously recreating her abandonment trauma dynamic with the unsuspecting psychiatric clinician. Step number 2, establish shared goals. This step, again, is absolutely critical and may need some time, even multiple sessions to explore. Our patients most often come with a goal of getting off my meds or getting on the right meds. When patients want to come off all their meds, we have to understand all the whys. Why does the patient want off their meds? Is it due to side effects, to cost, shame, pushback from family members or friends or other clinicians, lack of efficacy? What is the meaning that the patient attaches to being on meds? What does the patient understand about their diagnosis or diagnoses? What does the patient believe is the role of psychiatric meds? Can they imagine a world where maybe reducing their meds to just the effective and tolerable ones might actually be a win? Or do they feel like the only true win is a complete elimination of all their psych meds? Now, for some people, getting off all their meds might be a totally appropriate goal. This might be a patient with no serious psychiatric diagnosis, but rather someone who has had psychiatric symptoms, even severe ones, but primarily due to life, work, or relationship stressors. But contrast this patient with someone who has had, say, 20 years of often severe and disabling OCD symptoms, or maybe depression so severe that it has led to suicide attempts or hospitalizations, or maybe someone who's had a history of 2 psychotic manias, or for many of our patients with bona fide severe psychiatric illness, coming off all their meds would be a recipe for disaster. Oftentimes, with the patients who want to come off all their meds, yet they also have a serious bona fide psychiatric diagnosis like bipolar 1 or OCD, I try to negotiate a middle ground. I try to join with them on the goal of eliminating every med that is either doing little to nothing, as well as getting rid of meds that are causing problematic side effects. It's kind of the harm reduction approach of deprescribing. Let's get rid of the bad stuff and keep only what is safest, what is best tolerated, and most helpful. Or looking at the other commonly voiced patient goal, that of, say, quote, getting on the right meds, end of quote. We could explore things like, what does the patient think meds can do? What would be different with the quote unquote right meds? Does the patient understand the difference between psychological symptoms and psychiatric symptoms? A major part of appropriate goal setting with these patients must involve building a shared and realistic expectation of what meds can and cannot do. Number 3, build success and confidence early. Once I have a good formulation and understanding of the complexities of the patient sitting in front of me, and only after the patient and I have come to an agreement about what we are trying to do with deprescribing, or even represcribing, we can then start the process of picking one med at a time to taper and stop. Again, back to my beloved running, training metaphors. Deprescribing is often a marathon. It's not a 5K. And we need to prepare the patient for the reality that we're going to start slow and go easy at first, but this process is going to require a lot of self-discipline and trust over months and maybe longer. What I do first, I typically ask patients to look at their med lists and give each med a rating. Either number 1, I don't think it's helping, or number 2, it might be helping, or number 3, I think it's definitely helping. This is a very helpful guide for me, as I don't want to start with any med that the patient thinks might be helping, even if I think it's extremely unlikely that the med is doing anything. Once I have a list of the meds that the patient thinks aren't helping, I choose the meds that I think are going to be easiest to come off of. Those that don't tend to have significant withdrawal symptoms, those that typically don't do much for patients over the long haul. Meds like bupropion or oxcarbazepine or hydroxyzine or buspirone. If a medication made my top 10 list, check out my April 2023 podcast on this topic, top 10 psych meds. If it made the top 10 list, I'm very unlikely to start with this med. Then I give the patient back the short list of the meds that both of us think aren't helping and are also not likely to cause bad withdrawal symptoms, and we start with these. This way the patient gains some early successes and builds hope for the coming challenges. Number 4, preserve sleep. The number one thing that will wreck any taper attempt and crush the patient's spirit and willpower is triggering severe insomnia. So we must try to put this off until the final stages of our tapering marathon, after the patient has built up miles and months of confidence and increasingly big wins. Thus, the early weeks of deprescribing are almost surely going to tread very lightly around benzodiazepines, the Z drugs like zolpidem, or the sleep-inducing atypicals like quetiapine or olanzapine. When our patients can get a restorative night of sleep, they have the best chance to be resilient enough to withstand the kinds of physical, cognitive, and emotional challenges that are all too common in the tapering process. Number 5, differentiate between withdrawal symptoms and those of relapsing illness. As a general guideline, most of the symptoms that patients report in the days and initial weeks of tapering down off of medication are very likely to be withdrawal symptoms. In contrast, relapsing illness, that's much more likely to appear weeks and months after coming off of medication. Let's say, for example, you're tapering off aripiprazole or desvenlafaxine, and you see worsening depression and symptoms or even suicidality within days of the med being stopped. This is almost surely a withdrawal phenomenon, not a return of illness. The fastest acting, the most powerful depression and anxiety and psychosis meds all tend to have the most rapid onset and severe withdrawal symptoms. Clozapine, for example, which arguably is the most powerful and effective psych med on the planet, also is well known to have a frightening psychiatric withdrawal syndrome if stopped too quickly, with rebound psychosis and/or agitation, mania, suicidality. In contrast, a patient who successfully tapers off lithium, for example, and then has a recurrence of suicidal thinking and agitation, say 3 months later, this is almost certainly the reemergence of illness, not a lithium withdrawal effect. When withdrawal symptoms appear, the best option is often to step back up to the dose where the patient was stable, then restart the taper, but much more slowly, again watching for emerging signs of withdrawal. This is a crucial point. Many deprescribing attempts end prematurely because of withdrawal symptoms, which are miscategorized as the return of illness. Again, the time course of the symptoms is critical here. Number 6, slow down as you near the finish line. Tapering most often gets physically and psychologically difficult just before stopping the medication. Imagine someone cutting back from, say, 20 cigarettes a day to 18 to 16, then to 14, and so on. The hardest cigarettes to quit are, without a doubt, the last 2 or 3. And similarly, tapering down an antidepressant or benzodiazepine usually goes fine, so long as you can do it slowly, sometimes over months. But coming off the last milligram or so can trigger a firestorm of withdrawal symptoms. The watchword here is hyperbolic, as in the hyperbola, the mathematical function where a curving line approaches the baseline with decreasing velocity over time. Hyperbolic tapering of psych meds often means that coming off the last tiny amount of the med might take up a significant fraction of the whole tapering period. And it's definitely possible that some patients may not be able to come off some meds without undue pain, even with many months of tapering. And this is probably most true of the benzodiazepines. Thus, the importance, as I said before, of shared goal setting. Again, I often suggest to patients that the best goal often might be to get on the fewest meds at the lowest doses possible, rather than a goal of no psych meds whatsoever. Okay, let's do a case example. This is a woman I saw a few years ago. Details have been changed to protect her identity. I think running through this case will help sort of crystallize some of these ideas about deprescribing. My patient was a 45-year-old married woman with quote-unquote generalized anxiety disorder. She came to me on escitalopram, Lexapro 20 milligrams for the last decade, clonazepam 1 milligram at bedtime for the prior 4 years, propranolol 10 milligrams in the morning for 3 years, and buspirone 10 milligrams 2 to 3 times daily over the last year. Her goal was to get off all her meds. She was worried about being on so many medications and also was thinking that the meds may be blunting her emotionally and or affecting her sex drive. Step 1 with her was the biopsychosocial case formulation. She was a chronic, lifelong worrier with a very neurotic temperament, perfectionistic, but no serious problems with anxiety until giving birth 10 years prior. And she had, at that point, very severe postpartum OCD. Was started on Lexapro 3 months after giving birth and got a really good response to this, and it was eventually titrated up to 20 milligrams and her symptoms went into remission. Over this time, last 10 years, supportive marriage, happy, healthy 10-year-old daughter. She worked as a teacher and mostly enjoyed her work. She said in recent years she was having more hot flashes, night sweats, as well as increasing anxiety without a clear cause. The clonazepam was started about 4 years ago for worsening insomnia. The propranolol was added in the last year or two due to emerging panic symptoms, especially at work. So rather than using the meaningless wastebasket, quote-unquote, generalized anxiety disorder diagnosis, again, which gives us absolutely no guidance about what we should do with her treatment or her meds, we could say we have here a woman with multifactorial anxiety, a lifelong worrying, neurotic temperament with sudden and severe onset OCD after giving birth 10 years ago, and then a more recent exacerbation of anxiety correlating with the onset of perimenopause. Step 2, establish shared goals. She told me her initial goal was to get off all her meds, but as we explored this further, she seemed most upset about the number of meds she was on, as well as her lack of libido. I wondered aloud about a new shared goal, one of getting her on the fewest meds possible at the lowest doses possible, while also trying to optimize her sexual functioning. We further explored the concept of sex drive and libido, and this also then led to a deeper dive into her sexual functioning, including her ability to experience both sexual arousal as well as her ability to orgasm. Step 3, build success and confidence early. I explained to her why I thought we should build some early wins and save the hardest tasks for later, and she agreed. So the easiest thing to do was to get rid of the propranolol and just change it to as-needed dosing, and that went easily for her. In fact, propranolol tends to work better that way. I usually have people take it 1 hour prior to a high-stress situation. And I asked her to just simply stop the buspirone. People almost never have any withdrawal syndrome from that. In my experience, buspirone is mildly effective at best. So this immediate change, we took her daily pill count from 4 pills to 2, and she was very happy with that. And then next, I suggested that we slowly taper her down to 10 milligrams of the escitalopram, the Lexapro. Do a month at 15 milligrams, then do 10 milligrams, and then stay there for at least 2 months to assess for any changes in anxiety or mood, sleep, and also reassess all aspects of her sexual functioning. And finally, I suggested that we cut the clonazepam by 0.25 milligrams a month until she reached 0.5 milligrams, and then we would switch her to lorazepam. And this brings up a really interesting fact. So the lowest available dose, at least in the US, of clonazepam is 0.5 milligrams, which doesn't sound like much, half a milligram. That's actually a very potent benzo dose, and 0.5 milligrams of clonazepam is equal to about 2 of lorazepam. So once she got to 0.5, the plan was to switch her over to 2, and then we could slow down the taper with the lorazepam. And all this time, I was reminding her of our shared goal: the fewest meds at the lowest doses possible, but not necessarily getting off all the meds. And contrary to what she was initially hoping, early in the process, I introduced the idea of actually adding in something, of adding in progesterone at night, as I believed the increase in her anxiety in the last few years was due to perimenopause, and that adding progesterone could help smooth out some of the hormonal storm. And she did reluctantly agree to that. Step 4, preserve sleep. Stevie Nicks of Fleetwood Mac fame, she once said that kicking her cocaine addiction was easy peasy compared to getting off clonazepam. Now, my patient came to me on 1 milligram of clonazepam, which doesn't sound like a lot, but clonazepam, again, is very potent stuff. Some people can come off 1 milligram of clonazepam in a couple of months. Some people may need a year, and a small percentage of people may never be able to get off it. So I suggested to her that we plan for a taper over months rather than weeks. Step 5, differentiating withdrawal and relapse symptoms. As I'd expected, the biggest challenge for her was tapering down the clonazepam. We had to slow the taper on 3 different occasions, as she had some pretty significant withdrawal anxiety and insomnia. She had initially mentioned that she felt possibly dulled on the escitalopram, and as the taper progressed, she began to notice that she could better feel the full range of affect, from joy to sadness, from anger to despair, and all in all, she thought it was worth it. Step 6, slowing down as we neared the finish line. Because we went slowly with the escitalopram taper, she did well until we got to 5 milligrams. But then she started to have a significant increase in anxiety. So after a few times of going back and forth between 10 and 7.5 and 5 milligrams, she ended up on 10 milligrams a day, which was somewhat disappointing to her, given that her initial goal was wanting to get off all her meds. So at the end, she ended up on 10 milligrams of escitalopram and 200 milligrams of progesterone at night. And on this combination, she generally reported feeling stable and healthy, with manageable levels of anxiety and improved sexual responsiveness, although without a clear increase in libido. So we didn't get her off all her meds, but she went from 4 meds to 1 med, as I don't consider progesterone replacement as a bona fide psych med. She reached the finish line of her tapering marathon, maybe not in the time she'd hoped for, but with a smile as she crossed the tape. Thank you all for listening. Love to hear any of your comments, questions, or suggestions. You can reach out to me through my website, craigheacockmd.com. We'll be back in 2 weeks.